Oh, and I see Jason and Kevin. And then we'll quickly off Gail.
Shelley and Gail, I'm at a ADHS meeting that's all day, and I've got to present at 1300. So I'm going to have to leave probably at 12:55. So I apologize, but it just happened that both these things got scheduled today.
Thanks for letting us know, Dr. Walter.
Sure.
I am back. Sorry, I lost all internet and phone reception simultaneously. So.
All right, Gail, the record, I've hit the recording button and
Okay.
we will have quorum, so I think we're all set.
Excellent. Sounds good. So a couple housekeeping items. We are recording the meeting, so everything shared on the meeting will be part of the recording. So that is anything by voice, video, or chat. We can go ahead and with the attendance roll, Shelley.
Amber Rice,
Here.
Dan Spate,
I'm here.
Franco Pesterman,
Present.
Frank Walter,
Here.
Gail Bradley,
Present.
Steve Gottsnaker,
Present.
Jason Johnson,
Here.
Joshua Gaither,
Here.
Julie Augenstein,
Here.
Kevin Foster,
Here.
Michelle Preston, I count 10. We have quorum.
Excellent. Thank you so much, Shelley. All right, we'll go ahead with the chair report. Starting with your packet, there is the attendance report that is attached. Just a reminder that in the bylaws, there is an attendance requirement. So if you do miss 2 or more consecutive meetings, Shelley will reach out to you to determine if you still would like to participate on the committee. For vacancies, we do have 1 vacancy right now. It's for a physician who specializes in severe acute head injury treatment or spinal cord care and who has demonstrated interest and expertise in emergency medical services system. If you're interested in that role, you can apply on the governor's website, which is bc.azgovernor.gov. Next, we'll just briefly cover the Naloxone Leave Behind program. There is a hyperlink from the agenda. This is just a reminder for the medical directors and agencies that we have put together with the help of the Education Committee some great resources for any agency that would like to set up a Naloxone Leave Behind program. This includes an educational PowerPoint that can be tailored if you'd like to your jurisdiction, resource pamphlet, which also can be tailored with resources for substance use disorder in your area, along with a hyperlink to order free naloxone from the Office of Injury Prevention as part of ADHS. So just wanted to make sure that everyone was aware of that. Next is recognizing our Trauma Awareness Month and EMS Week. So May is Trauma Awareness Month and this week is EMS Week. So we wanted to take a minute just to recognize both of these. You will see some nice infographics that Shelley is displaying here. They are also hyperlinked in your agenda, and these were sent out via Gov Delivery this week as well. So I just wanted to make sure we take a minute to recognize both Trauma Month as well as EMS Week as well. Next on the agendas are the 2020 Arizona EMS System and Trauma Snapshots. If you can share those. These were initially put together for 2019 data year as the first time by Julia Vinton. And they are a really nice kind of one-page summary of what our EMS system looks like in Arizona. So I'll just briefly kind of cover some of these. You can see for 2020, there were just over 1 million records in AZ peers and approximately 890,000, which were used for our EMS data set. We have 166 EMS agencies that submit data. You can see some of the other highlights as we move down. There is the prevalence of primary and secondary impressions for categories of interest, as well as mortality by primary and secondary impression for categories of interest as well. And if we can share the trauma one. Again, this for trauma is a really nice summary you see across the state with the map of the geographic layout of our 47 trauma centers, including the number of level 1s, level 1 pediatric, as well as our level 3 and 4s throughout the state. You can see the total number of trauma cases, the top 6 mechanisms of injury. I think no surprise to anyone that falls are by far the top category, followed by motor vehicle crashes. And you can see that pediatrics, that accounts for approximately 10% of all of our trauma. There was a question that came up this morning at STAB for the definition for this snapshot. It is 0 to 17 age group. And then you can see the median injury to emergency department arrival time. Obviously, is going to be dependent and different for urban versus rural settings. You can see in the urban setting, 48 minutes and rural setting, 79 minutes. So just an overall really nice snapshot of the EMS and trauma system in the state. And these are available on our website as well. Any questions on either of those?
Gail, this is Frank. I'm sort of surprised to see that the urban arrival time from trauma to presentation to emergency department is 48 minutes. The golden hour is almost used up. Any thoughts on why it's that long? Does this include all ambulance transports or ambulance and self-transports?
So in terms of Vatsal, if you can maybe speak to this, I believe that this is for EMS only. Is that correct?
Sorry, Dr. Bradley, can you repeat the question?
Yes, for the median injury to emergency department arrival time, Dr. Walter had a question regarding the time for urban arrival at 48 minutes. Just to clarify, these patients are only EMS arrival, correct?
That's right.
Okay. So certainly a number of factors that could be contributing, I think includes, for the urban setting, this can include both suburban and urban. So you may have areas from the time of injury doesn't always necessarily indicate the exact time of dispatch as well. So that would include time of dispatch to getting on scene, preparing for transport and transport to the hospital. So I think that may account for some of those time frame and delays.
Thank you, Gail. Thank you, Vatsal.
All right, next on the agenda, I just wanted to update the group. We had mentioned in January that we were waiting on NASEMSO to publish the final model EMS clinical guidelines. Those were delayed a little bit because they were waiting for ACS to publish their updated field triage guideline, which was published. Once that was published, the NASEMSO group did go ahead and adopt the updated ACS field triage guidelines, and those were added to the model EMS clinical guidelines. So those were adopted in March of 2022. PMD has started the process of updating the Tttgs based on the version 3 model EMS clinical guidelines, with a pretty hopeful process to get this to this committee for final vote at the September meeting. So they are going to have a special session in June for preliminary review and then a follow-up meeting in July. So I just wanted to put that on this group's agenda. We are hoping to really do this update within this calendar year so that agencies can utilize that for their 2023 guidelines. Any questions about that process? All right, hearing none, I will go ahead and turn it over to Chair Garcia for the Bureau report.
All right, good afternoon and happy EMS week and Trauma Awareness Month. We just wrapped up the EMS Council meeting where we did highlight some EMS resiliency resources and really wanted to stress the importance of mental health, self-care, and just overall resiliency. We will be refreshing some of the resources that are available on the Bureau's website for our frontline providers. And just want to take a moment to say again, thank you so much to everyone on the line for everything that you do. I'll go through some quick legislative and rule updates. It has been a busy legislative session, and the department this year is not sponsoring any EMS bills, but we are tracking a handful of bills as they make their way through the process. There is a CON bill that I believe is on its way back to the House right now. And certainly we will be keeping stakeholders informed as we learn more information. And if there are any questions for the Bureau on pending legislation, please let us know. We right now at this point in the year are awaiting our budget with our EMS appropriation moving forward for next fiscal year. And again, we'll keep everyone informed. On the rules side, we have new air ambulance rules that will go into effect on June 5th. That rulemaking was over a 2-year plus process, and we've been communicating closely with our air ambulance providers, getting ready for those rules to be implemented next month. Again, if you have any questions, please let us know as we prepare for that implementation. The ground ambulance rules are still open and stakeholder meetings are ongoing. The department has recently posted some resources on our rulemaking website. If there are any questions on ground ambulance rules, we don't have any other rulemakings open at this time. We have not yet received approval to open up scope of practice or any other rulemaking, but certainly we continue to monitor national, statewide, and local trends to see what we need to keep an eye on and seek feedback from this commission as well. Over the last month, we had a trauma program managers and medical directors workshop, which was well attended and well received. Next, we're kicking around the idea of setting up a base hospital and medical director workshop. And we'd love to take that opportunity to be able to introduce new staff and, of course, review program information with stakeholders. So please let us know if there are any questions about some of our new team members coming on board and how we can build out those connections to make sure that we're sharing information both ways. And we look forward to a good agenda today. Thank you, Dr. Bradley. I'll turn it back to you and Vassal next.
Thank you.
Thank you, everyone. I'm going to share my screen so you guys can see cardiac arrest and opioid data. So we are continuously monitoring cardiac arrest and opioid cases by month. And as we see, we have a slight increase in the cardiac arrest cases in the month of March and then April compared to the last year. But we have agencies added also to our AZPO. So this increase is not actually increasing the number of cases, but because new agencies submitting data to us. So that it's not that high. Cardiac arrest disposition, the percent dead, there is a slight increase in the number of the percent of people died due to cardiac arrest on scene compared to last year in the month of March, and a higher increase in the month of April. And then the transportation, we are seeing, it's less compared to what it was the last year. For the opioid incidents, there were total 859 cases of opioids in the month of March, and in the April it's slightly decreased from 859 to 765 cases. And the disposition, the death rate it's been almost in the 7% range. It's continued to be in the 6-7% range. That's about it. Any question? I think Dr. Gaither has a question.
Sorry, I actually had a question for Rachel of Force. Finish what you got, and I'll have you up with my question later.
Okay, all right. Sounds good. Thank you, guys.
Thank you, Vassal. Josh, did you want to go back to your question for Rachel?
Sure. it's a really silly question. I apologize, Rachel, but where's the best place to see the air medical rules that will go into effect? Are they currently in the rule book on the website, or are they somewhere else?
They've not yet been published in the Bureau's rule book that we maintain on our website. And I don't believe they are published yet by the Secretary of State in the registrar, but they are on our completed rulemaking list. And so the short answer is, Josh, we can drop the link into the chat for this group to be able to look at those rules that go into effect in June. Is that helpful?
Yes, that would be great. Thank you.
Yeah, and the final version will be posted on the Secretary of State website, we anticipate within the next quarter or so.
Great. Thank you.
All right, excellent. Thank you. I just wanted to give a brief update regarding the SHARE program. Just for everyone's awareness, we started a process last July of really trying to clean up the database of the cardiac receiving and referral centers. And when I say we, I really say Julia Vinton, who did a ton of work of really making sure we reached out to every center throughout Arizona to see if they still wanted to be participating in the program and met the criteria. We're very pleased that all but one facility has submitted all of their documentation. Our goal is to make sure that we do this on a 3-year cycle to really ensure that facilities are maintaining the capabilities that they are stating if we're asking EMS to bypass other facilities to get to them. The other component of this is that we did identify a few facilities that have downgraded their cardiac receiving center status to a cardiac referral center status. And it's really important that as that occurs, we are able to get that information out to EMS. The other nice positive is that we've seen a significant improvement of data reporting to U of A, and we are much further ahead in our data reporting for 2021 than we were for 2020. So our hope is to get the report out for 2021 much sooner. Dan, I don't know if there's anything you would like to add to that as well.
Nope, you did a great job. Just our thanks to I know many on this are involved with hospitals that are CRCs, and our thanks to the hospitals during really tough times of doing kind of coming out of the pandemic, with the exception of, 1 or 2, maybe 3 hospitals out of 40. Everybody's doing a remarkable job of doing outcomes, and I think it's not an overstatement that we'll probably be 7 months sooner with our report this year. Last year, COVID had just blew it up. So great job. And thanks to the Bureau for really re-energizing it and working with the hospitals so that we're sure that CRC status actually means something. So thanks to Gail and Rachel, especially on that.
Thanks, Dan. All right, next on the agenda is standing committee reports. Julie, you're up first for TEPI.
Thanks, Gail. The Trauma Registry Users Group provided an update that the AZPR's ASTR linkage is working well, and there are new data dictionary changes in place to reflect the other NTDB updates. Carrie Lewis was approved as the vice chair of the group, and there was a standing item that was a discussion and amendment for discretionary reports. It was noted that no reports were produced since the list was launched multiple years ago. There was a motion approved to remove the list as a standing agenda item and amended to maintain it as a reference for future EMS trauma reports. And then the trauma annual report was discussed regarding adjustments for the next round of reports. And there was discussion support to look at rural versus metro data and differences between trauma centers by level. The status of the emergency declaration and the current data reports on the public opiate dashboard were also reviewed. And there were no outstanding action items to be considered at the next meeting. And our next meeting is July 21st with no upcoming events were reviewed. That's it for me.
Thank you.
I can do the education.
Okay.
If we don't have to do there. Education draft minutes from March 17 show that the meeting minutes from November were approved. The group approved a training for maternal resuscitation and interventions. The group also approved a training for naloxone for pediatric patients. those are both posted on the website. They approved the formation of a work group to create curriculum for SDRs. They approved a work group to work on the Tttg. No, that's CMD. Sorry. Motion the SDRs, and then they approved another work group to look at the Stop the Bleed resources and Life Vest resources. That's it. Sorry.
Thank you, Shelley.
And those are the action items. Thank you.
All right, next up, Josh for PMD.
Thank you, Dr. Bradley. So the PMD committee met, sorry, I'm too far down to tell you the date, met on March 17th at noon. There was a attendance report. There is an open seat for a representative from SAMES, which that regional committee is working to fill. Aside from the normal updates, there were several discussion and action items. We discussed briefly EMTC scope of practice, which is currently not open for changes. We discussed a hospital-based paramedic practice, and there was interest in exploring the possibility of a work group to generate resources and guidance for hospital-based paramedics and their administrative oversight teams. We also looked or reviewed the collaborative patient offload plan that is under development by the central region, and we have implemented down here in the southern region. And then finally, we discussed the work plan to update the triage, treatment, and transport guidelines, and that work plan is currently underway. That was it.
All right, thank you so much. Next, Adam for PACES update.
Good afternoon. Thanks, Dr. Bradley. We last met on March 17th as well. We have no vacancies at this time. The pediatric naloxone training that was mentioned prior is now live on the Bureau's Education and Independent Study website, so you can access that. PACES is currently fielding 2 work groups. One of the work groups is a pediatric behavioral health work group, and we are looking for people that have a lot of knowledge in their behavioral health systems around their communities. And so if you happen to know a great deal about behavioral health or know someone who does, please, we could use you. The other work group has just been formed during the last meeting, and its task is to identify gaps in training in EMCT training. And so if that's something that might interest you, again, I'll put my email in the chat for any volunteers. Our next PACES meeting is July 21st, and that's all I got, Dr. Bradley.
Excellent. Thank you, Adam. Next for discussion and action items, if I can get a motion and a second to discuss, amend, and approve the MDC minutes from January 20th, 2022.
I move to approve the minutes.
Thank you. Frank, can I get a second?
It's Josh, I can second.
Thank you, Josh. Those are in your packet, and Shelley is scrolling through as well. Are there any recommended amendments to the minutes? Hearing none. Anyone opposed to the meeting minutes as presented, please say nay. Any abstentions? All those in favor, please say aye.
Aye.
Aye. Aye.
All right. Those are approved. Thank you. Next, we have, I need a first and a second to discuss, amend, and approve MDC meeting minutes from special meeting on February 10th.
I move to approve.
Thank you, Frank.
Second, Jason.
Thank you, Jason. Any recommended amendments? Hearing none. Anyone opposed to the meeting minutes as displayed, say nay. Any abstentions? All those in favor, please say aye.
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 All right. Thank you. Next up on the agenda is an update on pilot project and ultrasound guided IV. Dr. Gaither.
Perfect. Thank you, Dr. Bradley. Thank you, Shelley, for sharing the screen here. The first slide we have up here is the list of participating facilities. You can see that we have about 20 facilities that are participating. We did add in a significant number of Honor Health facilities just like 2 weeks ago, so that's why they have no submissions yet. So there are a few that have added on in the last 2 to 3 weeks that we don't have submissions for. You can see here, this is how many ultrasound guided IVs have been placed. If you move on down to the next slide, Shelley, or the next page of the report, this is the success rate. You can see overall the paramedics have an incredibly high success rate. This is total success, and the pilot project limits paramedics to 3 attempts. So overall success after 3 attempts. If you scroll down to the next section of this page, you can see the number of attempts made. So 1 attempt by 558, the vast majority, 2 attempts, and 1 individual had 3 before success. If you again scroll down, you can see the location of IV placement. I was actually a little surprised by this. Forearm and antecubital fossa were the most common, followed by the veins higher up in the arm. I am a little surprised there are so many forearm IVs, as those tend to be smaller and actually more difficult to access. So interesting there. If you scroll down, I think the real thing for this committee to be aware of is the complication rate. As a pilot study, of course, we're closely monitoring for any complications. You can see here we have less than a 10% complication rate, which is kind of what we would set as the threshold for discontinuing the study. If you scroll down, you can see what those complications are. Hematoma at the IV insertion site, infiltration, and other. When we actually look through those other comments, most of them were probably infiltration. However, there were some complaints of pain at the IV insertion site. That's kind of anticipated. So those are the complications, and I believe that's the last page of the report. I'm happy to answer any questions on this. For now, our tentative plan of our kind of QI study team, which includes, she may be on here, Dr. Josie Acuna, as well as a medical student from the U of A, is to collect this data for a minimum the next 3 quarters to see how things are going. So we'll continue to collect and report back to this group on a pseudo-quarterly basis. I'll stop there, and any questions for the pilot project?
Thank you, Josh. It's a great summary, and nice to see a large amount of data that's being collected so quickly. Dr. Godzinker, I see you have a question.
No, thank you. This is an awesome study. Quick question. Is the end goal with the thought of maybe getting ultrasound available for medics on the rig to establish IV?
So I should be very clear with the first comment I'll make, and then I'll get to your actual question. I do need to be very clear. This isn't a study. We're not doing research. This is a quality improvement project. And so all findings are limited to those quality improvement type of caveats. This is a very limited data set. The second point, which I'll make, which is actually your question, no, this is intended to only be used in the hospital setting. We would not be able to generalize this information beyond that. And I personally, clearly the out-of-hospital environment is very different from the in-hospital environment in terms of the equipment you use, the motion, all those types of things. So for the time being, this is simply in-hospital paramedics.
Right on. Thanks for clarifying.
Excellent. Any other questions for Dr. Gaither? All right. Next in the agenda, if you can open under item D1, Shelley. Just to give a little bit of background on this, STAB did decide to table the motion this morning at their meeting, but I wanted to make sure that this group was aware that ACS updated their national guideline for field triage of injured patients, and this was just published here a couple months ago. This is their first update since 2011, so this is a significant update, and they've really created a pretty extensive kind of package to help get this information out there. There's a whole website devoted to this. The website includes training packets, the evidence behind their decision-making, and why these changes were made. When this was presented to STAB, STAB really liked most of the changes that appeared under the red category. I'll just highlight a couple things that are some of the big changes. You'll see under injury pattern, there's some new terminology of active bleeding requiring a tourniquet or wound packing with continuous pressure. That is new from the previous version. You'll also see under mental status and vital signs that GCS has been updated to a motor score only. And this is really kind of aligning that an overall GCS is often inaccurately recorded both in the pre-hospital and hospital setting. But if you utilize just the motor component and specifically unable to follow commands, you can really delineate a sick patient pretty quickly. You'll also see that the blood pressure criteria have changed. So it's a much more specific for the younger pediatrics, general adolescent and adult. And then when we get to the patients 65 and above, you can see that there's a different criteria noted there as well. So that section was pretty well received by the committee. There were not a lot of questions on that one. If you can scroll down to the yellow category, the yellow category is, I think, where there was a little bit more discussion. And so the group had decided to table the item. I did discuss with them that we are hoping to have some form of this adopted into the updates of the Tttgs. And so the goal will be to have a special session where we look to have STAB meet with participation from anyone who would like to participate to get something approved. The couple changes just to highlight here, you'll see under mechanism of injury, there's some very specific verbiage regarding children who are unrestrained or improperly restrained. And you can also see that the fall criteria is a fall from height greater than 10 feet for all ages. So that is a change. The part that raised some question and where I think stemmed away from an actual vote was under the EMS judgment. There was some conversation regarding the head injury component, anticoagulant use, and where that should fall on there. And so after some discussion back and forth, the group voted to table this and reconvene a special session to address. So I wanted to make sure that MDC was aware of the conversation. Ultimately, the final decision will come to MDC as staff would make the recommendation and MDC would vote on that to be included in the Tttgs. So I wanted to really bring that forward here.
Hey, Gail, it's Josh Gaither. I have obviously spent a good amount of time reviewing this. I was impressed by the ACS group's work on this, the evidence base that they put behind it. And certainly my opinion I would be in full support of adopting this as is. I think deviating from it would really probably set the wrong precedents for following true evidence-based medicine and evidence-based protocols for EMS providers.
Thank you, Josh. I think there was definitely some feeling from some members of the group as well that it would be best to adopt as is, and we can collect data to see if this is appropriate or not. But unfortunately, there was some too much dissent. This is one of those things where, it did go out to everyone ahead of time, but I think many of the members had not actually seen this until the actual meeting. And so hopefully now that people are aware that we need to have a vote on this, this calendar year, we can get something approved moving forward. I also am quite impressed with what ACS put into this whole process. Their website has a ton of resources, really good training PowerPoints, and how to educate people on implementing this, the evidence behind it. So just a very well done process. Any other questions or comments? I know a few of you were also on the STAB meeting, so feel free to speak up if you have any other thoughts on this or feel differently. Certainly, this is the first update since 2011, so this is significant. We're well over a decade since this was last updated, both nationally and here in Arizona. So we want to make sure we take time to have some really thoughtful conversation on this.
Gail, this is Frank. I'm sorry I wasn't able to catch everything. What were the questions raised at the STAB meeting regarding the yellow criteria? I apologize.
That's okay. So some of the conversation was whether there should be, as opposed to EMS judgment, if anticoagulant use and head injury should be moved to the mechanism of injury criteria. There was also discussion that under the first bullet that the adults greater than 65 with significant head impact, whether that verbiage was too strong, if it would should potentially have just head injury without significant impact. So those were some of the conversation pieces.
Thank you.
Any further questions or comments from anyone who was in the meeting earlier or from this group?
No problem. I'll shut your door.
All right. So what we will certainly do, we will make sure that all members of this committee, if you are not on our Gov delivery, but you otherwise get meeting invites from us in a different manner, we will make sure that when the special meeting is held for STAB, that this group gets invited to that as well. So we will make sure that that gets out to everyone. Next is just a brief discussion on the EMS patient offload plans. I know we have spoken about this previously, but just really wanted to emphasize that the regional councils, as well as these meetings, are a great opportunity to share best practices. And the process that was put into play in Southern Arizona with the offload plan to address prolonged offload times was quite successful there. And the central region did model after that as well and implemented their own offload plan, which was almost identical, that went live within the past month as well. So really want to take the time to just recognize all the work that went into that for both the Southern and Central regions, and really just say, you know, these are the opportunities where we can figure out if something works well or maybe doesn't work well in one sector, then we can bring that to the rest of the state. Any further comments on the offload plans from anyone? All right. Next, we will move to discuss critical care and community paramedicine certification pathway. I will hand that over to Chief Garcia.
Hi, Dr. Bradley, again, and MDC members. We're teeing up a couple discussion slides for this agenda item. So give us just a moment. All right, looking good, Shelley. Thank you very much. So for this discussion, we'll provide a little bit of background, and I hope everyone's able to see some of this text here related to some of the current rulemaking we're doing for ground ambulance.
Rachel, sorry to interrupt. You're a little quiet there.
Oh, can you hear me now, Gail?
Much better. Thank you.
Okay, thank you. So right now, for Article 9 ground ambulance rulemaking, we are in the process of defining critical care services. And for the purpose of this discussion, we wanted to ask MDC if they had any feedback on the definition that you see here for critical care services or staffing requirements for critical care transports. While we're doing this ground ambulance rulemaking, we're also taking a look at other states in terms of how they have addressed critical care and community paramedicine certification pathways, and some considerations for certification, training, and scope of practice needs as the EMS field evolves. If anybody's interested in looking at the current draft rules that we have provided the link here on this slide. We'll go ahead and go to the next slide. This is a website where we've been able to review critical care policies by state. That link there will take you to a website that lists all 50 states and whether they have implemented a critical care paramedic license, certification, endorsement, or expanded scope of practice. It's been interesting to see how many states have already done this, and we know many more states are in the process of reviewing this and contemplating endorsements and expanded scope of practice. Next slide. So finally, these are the discussion questions we wanted to bring to MDC. First, like we said, we're looking for any feedback this group has on the critical care services definition and staffing requirements for those transports. Secondly, we'd like to know if the committee members have any additional feedback on critical care and community paramedicine certification and any considerations for not just certification, but also training and scope of practice, again, as this field evolves. Dr. Bradley, I will pause there. I did not see our rule writer, Ruth Ann, join the call. So I will ask you, do you have anything to add to this discussion?
Just a couple of quick items I wanted to clarify. So we are not opening rule. I wish we were, but we are not currently opening rule to address this. We are just looking to get feedback because some of the current open rule writing does reference critical care. And so we want to make sure that those definitions are consistent if we are able to move forward to develop a critical care pathway in Arizona. The other thing to mention, there are several other states that are on the NASEMSO medical directors listserv that are also in the process of developing a critical care pathway. So the list that was displayed before, on top of that list currently in the US, there are a number of other states that are actively working on this process. That is all I have to add. Thank you.
Rachel, could you please go back to that first slide that I think had the definition on it? Yeah, that's it. Thank you. Thank you.
This is Franco. If it's okay, I'd like to just repeat a comment I made in the last hour for this record as well. Again, I applaud the Bureau of getting ahead on this and taking a look at what other states are doing. I see a lot of emphasis being put on the memorialization of scope of practice, initial education, certification, but what I don't see is any emphasis put on analyzing the oversight needs in terms of, agency level credentialing of these providers, quality management, and the infrastructure and human resources that it takes to oversee. As Chief Garcia, used the perfect term, this is an evolution. It's an evolution, it's an advancement, it's an enhancement of EMS practice. And, what perpetually seems to be a problem is that, especially for I'll speak for, as a medical director of a base hospital type of program, we're sort of at the mercy of our hospital organization, and there's a perpetual under-resourced problem. And so as the expectations of our communities and of our providers is this, ongoing advancement of care, increase of sophistication and evolution, it's vital. I rely on entities like this one, like the state of Arizona, to add equal emphasis on oversight and the resources that are appropriate to that evolution of care. Because without that, a case is very difficult to be made at the level of our agencies and our hospitals.
I just had a brief thought on the definition. You could shorten it after the word injury, and just eliminate the words acutely through R and just say an illness or injury that is life-threatening and requires constant monitoring to avoid deterioration of the patient's condition, and then get rid of that parentheses at the end. Just a thought.
Thank you. I don't know, are you able to, Shelley, maybe just make a note in that document so that everyone can see what Dr. Walter is suggesting?
I think it would just shorten it up and you wouldn't lose anything. And then you could just say that, and rather than are, an illness or injury that is life-threatening and requires.
Yeah, I do. That is definitely much more simple.
Basically, it's critical because they could die.
Yes.
And then we'd have to change required to requires with an S.
Great feedback. Thank you.
Sure, no, thank you. Just a thought.
Ruth Ann will be very happy to have gotten feedback from both committees, so thank you.
And Dr. Walter and Dr. Castro-Marin, thank you so much for that feedback. Does anybody have any comments on staffing requirements for these types of transports?
Just a thought. I think it's really important that medics be able to transport patients that are critically ill between facilities and monitor infusions and things like that that aren't typical, to speed up transport so folks don't have to be transported with a nurse or a doc from the sending facility to receiving, as long as the medic's up to the task and trained for the task, as Franco mentioned, and that process gets monitored. The only concern that I have would be that it would delay interfacility transports that are necessary if you've got to wait for somebody that's got a specific certification or endorsement or that sort of thing. So I bring those up as questions and thoughts. I don't have answers, and I'll follow the wisdom of the group.
Thank you. I think those are definitely some component of the conversation that does need to be had moving forward. And I think as we look, to potentially developing a critical care pathway, does that give more opportunities for paramedics to help transport these patients with adequate training and oversight to help expedite getting patients to definitive care? So definitely all great points. All right, any further comments, or should we move on? All right, hearing none, we will go to item G. TJ, are you available to give a brief update?
I am. Can everybody hear me okay?
We sure can, thank you.
Okay, I will try and keep this brief. Starting with the second item, because there's been no substantive changes. The distributive education limits have not been changed, and according to the National Registry, will not be changed until after their meeting next month, if they are changed at all. So there's no updates there. On the sunsetting or the redesign of the ALS psychomotor testing, the expert panel has met a total of 8 times so far, 4 in 2021, 4 in 2022. And as the 2022 meetings have progressed, they've become more comprehensive in size and scope. January started with reduction, or at least an introduction of a reduction in the time frame to wait for a retest from 15 days down to 7. February meeting focused on clinical judgment and I am going to insert the DOI for the peer-reviewed journal that they've been focusing on with the clinical judgment and EMS focus that's going to be driving the changes with the redesign. In the March meeting, they focused on some templates for performance evaluation and working with the different vendors from EMS textbook publishers to the educational support vendors to develop some resources, not only for students, but also for the testing programs. And then in April's meeting a few weeks ago, they started to introduce the technology enhanced items that they're going to be adding to the computer-based tests. Instead of just the multiple choice, now we'll have some drag and drop, checkbox, build list, and sequence items. And I'm going to also drop into the chat a little amplification of that material that they're focused on now. And again, probably going to be introducing some of these items in late 2022 to the current testing items, and then full implementation won't take place until either mid or late 2023. But they're definitely moving forward on these items. And if anyone else has any specific questions, please ask them now or shoot me an email. I'll do my best to get you the information that you need.
TJ, quick question of clarification for you. When you discussed briefly the distributed limits, you mean they have not changed what is currently required, not they are going to continue to require no limit?
They're currently not limiting the hours that are obtained through distributive education. So there's no limit currently, and they're not going to make a change to that if they do until at least following the meeting in June. So there's no anticipated change. Right now, there is no limit.
Perfect. So maybe just some feedback from the end user's side. That's really not clear on their website. And unfortunately, if I was a paramedic or if I was a medical director running a recertification course, right now, it appears that 70% of education must be live, and there's no verbiage on their website to state otherwise. So if you have the opportunity to provide them with that feedback, because of the research cycle, if we wait until June or July and don't provide live education, you've already used up your 30% for many of our longitudinal research programs. So if they could clarify that on the website, it'd be greatly appreciated.
And I can definitely suggest that to them. They have had a substantial number of meetings with program directors and the training program managers on a very frequent basis. And they've made it clear to all of the folks attending those items that there are no current limits to that. Again, I can't make the changes to their website, but I can definitely suggest they make that more clear. But I think they've done it a little more effectively through the one-on-one meetings that they've been having basically monthly or more frequently for the last year or so.
TJ, if we were interested in participating in those types of meetings, how does that happen? I don't actually even know how to participate, and I'm afraid to admit that, being as I'm a medical director, training officer, and run a degree program in EMS.
Well, so they put out a number of invites on a relatively frequent basis for that. They have a section on their website that is dedicated to the training program managers. So there are some hoops that you need to jump through on their end to receive that designation. But if you want to shoot me an email, I will do my best to kind of guide you through that process to make sure that you have all the resources you need.
Thank you. Appreciate that.
Absolutely.
All right. Any other questions for TJ? All right. Next, we need a nomination and vote on a member to fill the MDC liaison vacancy for the Education Committee. So looking to see anyone who is on this group that would like to be a liaison to the Education Committee. That meeting, the education meeting, is on opposite months from this meeting and does meet at 10:30. If we don't have any nominations from the floor, we can always table that to the next meeting.
This is Jason. I can do it if nobody else wants to.
All right. We will take that nomination. All right. Hearing no other nominations, all those in favor of approving Jason Johnson as the liaison to Education Committee for MDC, please say aye.
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 All right. Thank you. Next up, I just wanted to get this group. I did mention it briefly earlier as well, but wanted to make sure everyone was aware of the timeline to update the Tttgs. PMD has started that process. We will be having a special session in June to kind of do the first pass on the feedback from those separate groups. And then we are hoping to bring back to this group in July a pretty thorough product. Any questions regarding that? All right. Any agenda items to be considered for the next meeting, please feel free to send those to myself or Shelley. Next, call to the public. All right. You can see the attached summary of current events. Our next meeting is scheduled for September 15th at 12 p.m. And can I get a motion to adjourn, please?
Motion, Franco.
All right. Thank you. All right. Meeting is adjourned. Thank you so much, everyone.
Thanks, Gail.